So it is week 6. We're halfway through already. It goes by very, very quick. Next week, is going to be exam number 2. We're doing the reviews this week. They are posted on your announcements. And as always, I will post all of the review recordings all in one post. I don't think it's for you to go looking for 5 or 6 different posts, looking for different professors. That's confusing. 3 courses, working, and then just normal life. I'm trying to make it a little bit easier for you to have them all in one place. This week, we're going to go over chapters 43, 44, hematological, immunological, and a child with cancer. Remember, anybody who didn't get that CJ Sims done last week, please go ahead and do it. They, especially if you're that borderline students, it will make a big difference in your grade. So make sure you do it at minus 10%, do that instead of not doing it at all right? Also remember discussion questions do have a lot of information on them, and I'll always put a comment. If you ever go back and look at discussion questions, you're going to see me put things there that are really important for you. So go back and do check them. This week you have another CJ Sims, and you do have your NCLEX questions in preparation again for your exam for next week. That's the way that they're scheduled right before your next exam. Anybody who wants to do a 1-to-1 because they really want to pass this exam, you're confused, please make an appointment with me. Your class is on Tuesday. I'll meet with you up till next Monday. So just let me know what's a good day and time, and I will meet with you and I'll ask you questions. What do you think about this, that, or whatever? Making sure that you understand what you need to know in order to get a good grade on the exam. And anybody who wants help with math, again, I did put a math calculation worksheet there. PN, RN doesn't matter. It's the same questions, different, of course, numbers, etc., that you'll see on either exam. So I did send you some examples of that. So let's go ahead. We're going to do our PowerPoint, and then we're going to be doing our Kahoots. So chapters 43, hematological and immunological dysfunction. Well, when would we know and what would we look for with these sort of conditions? Well, hematological is usually something with the blood, CBCs, white counts, platelets, bleeding, something's going on there. Immunologic, you're looking at the white blood cells, right? So what are we going to do in order to find out what's going on with this child? Well, first of all, it's going to be that assessment. What is the child complaining of? I mean, this could be a child who's alert and active, and all of a sudden they're tired, they're lacking energy. They're not just being themselves. That is a clue. Kids are usually active and mobile from the moment they wake up to the moment they go to sleep. When you see them not doing that, that's, one of those little bit of a red flag. Also, um, these children, when you see those things, what are we going to do to diagnose? Well, a simple CBC is going to show us a hemoglobin and hematocrit, right? The hemoglobin hematocrit, why do we look at that? Well, how is oxygen and nutrients carried around by the body? It's on the red blood cell, right? Oxygen and iron. And if you don't have enough red blood cells, your hemoglobin's low, you're not getting the oxygen, you're not getting those nutrients, the iron to give you all that energy. So just a simple CBC can tell. I mean, looking even further ahead, a platelet count can look at bleeding problems or some sort of immune thing going on with a child. So that history, physical, simple CBC, and then knowing that toddlers, believe it or not, these are those finicky eaters. And they go into what I've said is a physiologic anorexia because they don't eat as much. I mean, they're as infants growing so much, they're eating and drinking like crazy. They become toddlers, and all of a sudden you can't, they don't want to eat. And you're like, they need to eat more. Well, not only do they need to eat more, they need to eat more iron rich foods. And of course, they become a little bit finicker. So toddlers are at high risk for iron deficient anemia, nutritional, because of the way that they eat. If you see a child that's being sick all the time, something immune's going on. And then, of course, bleeding could be the platelets, or it could be one of those pleading coagulopathy lab exams like a PT, PTT. They're prolonged. Something's going on here, but we have to figure out why. So anemia, most common of all of the hematological disorders, it could be due to many different things. It could be a decrease in the number of red blood cells or hemoglobin. It's because they die quick, you're not producing, or they're just weirdly shaped. And when you don't have that, your oxygen is not getting around to your body, and that's what causes all of this being tired. Your body's not getting the nutrients that it does need. Now, it's not uncommon for a 6-month-old child to have a low hemoglobin and hematocrit because at birth they get mommy's good stuff. Your hemoglobin hematocrit's really good. And then their body doesn't start making cells till 3, 4 months, and it takes a while to catch up. And mommy cells do die off because they don't live forever, right? So hemoglobin of 9 and 10 on a 6-month-old is absolutely normal as long as they're not symptomatic. Okay, so as they get older, this is not normal. They should be a normal 12, 13, 14 hemoglobin. Now, with anemia, what do you see? Well, you suspect a child of anemia due to their assessment and they look pale. The first thing I actually do is I listen to heart sounds. And why do I listen to that? Well, these pictures show you with anemia, you have a little bit of cells and they bounce off of each other, and there's a when you listen to their heart sounds. It's not chikung, chikung, chikung normally because those cells are bouncing off of each other. So you hear that. Okay. Normal blood cells, normal hemoglobin, hematocrit, those vessels are full. You don't hear all that swishing going on. So that's the first thing that's going to tell me, besides, of course, assessment and seeing the child pale, etc. It's also that heart sounds and what I do here. You know, the heart's pretty cool. It tries to give oxygen and nutrition to the body, and it does increase the heart rate, trying to get blood around, oxygen around, but there is no cells, so they're not getting around. So you're at high risk for that heart to start to fail. It gets tired. I'm tired of pumping a lot. There's not enough cells. I'm trying, but it's not working. It causes, that cyanosis, of course, and there will be some sort of growth retardation in some way, even like delays in growth and development. So this is read out of your book. Decreased red blood cell production, an increased red blood cell loss, and then an increased red blood cell destruction. So either way, any of these, you're not getting enough of the red blood cells. So let's start with decreased red blood cell production. The first thing we look at is nutrition. Well, iron deficient anemia, number one, most common of all of them. Your diet is not rich enough in iron, therefore, you're iron deficient anemia. The second one that we do see is B12, the intrinsic factor. It's in the stomach, which helps break down nutrients for the body to eat. You know, those are the two that we do see with nutrition. Now, bone marrow failure, and I'm going to go into it more closely as we go forward, but aplastic anemia, it's red cells, white cells, platelets are all decreased. So you're talking about anemia, you're talking about no defense against infections, white cells down, platelets are low, you're looking at bleeding. So that aplastic anemia is a big anemia. And then, of course, ALL, acute lymphocytic leukemia. Of course, that's going to be your white blood cells. It has to do with bone marrow failure. Now, increased red blood cell loss. Well, one of the things that we see that sometimes will diagnose bleeding coagulopathy issues in children is a nosebleed. And I'm not talking just one nosebleed. I'm talking more frequent and becoming more frequent. And the bleeding really is bleeding a lot. And I'm going to go into what to do for that in a little bit. But sometimes that is going to clue us into what's going on. It could be hemophilia or it could be ITP, um, idiopathic thrombocytopenia purpura. Say that 3 times quick. But remember, ITP is all about platelets. Not enough platelets, it causes bleeding. Okay, petechiae and ecchymotic areas. And DI say is just overwhelming sepsis. I don't go deep and down into that because even as seasoned nurses, it's a very difficult thing to understand. So let's just get the basics here. And as you go forward, you'll understand more about that. Now, increased red blood cell destruction. Sickle cell anemia. I mean, you've all heard of that. That's your African American. That's most are affected. And then thalassemia, Cooley's anemia, the most severe of them. Those are from the Mediterranean Sea, people from there. Those are the two things we think about that. And then, of course, if you are under treatment or been exposed to radiation or something, these things can cause that increased red blood cell destruction. If you're on chemo treatment, getting chemotherapy, it doesn't just kill bad cells, it does kill the good ones too. And that's why many children under, let's say, getting leukemia treatment will also be getting blood transfusions because their red blood cells are being killed also, and we need to boost them up. They're also getting platelets because those are killed too, and we'll have bleeding if we don't. So, diagnosing, what do we do? Well, of course, I said first, that history gives us a big clue, and then a simple CBC is going to give us information that we do need. Now, in this case, we do need to figure out what happens. We just don't treat the symptom. But if your hemoglobin and hematocrit are really low, we need to give you a transfusion now before we figure out what is the problem. Why is it hemoglobin so low? Is it being destroyed? What's happening? So transfusions are given, and we do that to increase the oxygen and iron given to the body, right? Now, if it's a nutritional problem, let's give the nutrition. I mean, B12, we give injections for that. Iron deficient anemia could be just diet, or it could be oral or IM, iron injection. So we're going to go into that some more. So, care for anemia. So, your hemoglobin hematocrit are low, you tire out easy, you have no energy. So, giving some oxygen can help in the hospital. It's debatable because you don't have a lot of cells, but you're trying to maximize what you have. And then rest, bed rest. Reserving their energy just for eating, especially in your infants. And then we will give some IV fluids just to give volume in the blood, especially if we're looking at low blood pressures. Now, when we're assessing children for anemia, we're trying to figure out what sort of anemia they have because, as you're seeing, there's quite a few. So, age of child, their racial, ethnic background, African American, Mediterranean Sea, are they from there? And then let's rule out the obvious. Is it a GI bleed? Because it could be as simple as that. So, a stool for occult blood will rule that out. Always with children, we've talked about this, quite a bit. Prepare them, get down below them, don't stand above them, talk quietly, be non threatening, be on their developmental level, and explain what you're going to do. And again, don't lie to a child because they don't ever forget. I mean, they have memories that even my 7-year-old grandson just, he doesn't forget a thing. And from many years, he doesn't forget things. So don't make that child think, "Oh, you're the bad nurse because, you hurt me and you didn't tell me." Also, as we're doing blood tests or all of these other things, make sure that they're prepared so they're not anxious, they're not fighting against you, because again, that burns up oxygen and that could cause other complications. So, iron deficient anemia. We don't usually see this in the first year of life. And why? Well, they're either breastfed with some vitamin D supplements, or they're getting iron fortified formula. At 6 months old, we start introducing food and we're giving cereals that are iron fortified. So hopefully, we're giving enough iron to this infant that won't cause that. Now, there's something called a milk baby. And what that is that child's been given milk, whole milk, 2%, whatever milk, but they're not given iron fortified formula instead of formula or breast milk. And they're not getting all the nutrients they need. That's what a milk baby is. So how do we treat it? Well, we're going to be given those foods that does have more iron in it. You're talking about green leafy vegetables and broccoli and green beans and peas. All of those, we do have those little jars of that food, right? And that's iron for them. Now, if they don't want to eat it, or it's not enough to get their blood levels where we want, we're going to give iron supplementation. Now, when you have a child who needs iron, usually the young ones are going to be getting a liquid. Now, that liquid is brown. It does stain the teeth. This is the one in pharmacology they taught you to drink through a straw. Now, another thing is iron supplements. When we drink it, it goes into the stomach, and the stomach acid breaks it down into what your body needs in order for the iron to be used. So you need that stomach acid. What does that mean? It is before meals, okay? So on an empty stomach. Also, they say give it with orange juice. Because again, orange juice is another acid, and that will help break it down. So never with meals and never with milk, because milk, again, coats the stomach and stops the stomach acid from breaking it down to a usable substance. Now, sickle cell anemia. Many of you have it, have a trait, or know somebody with it. What you need to know about sickle cell is if both parents have just a trait, every child has a 25% chance of getting the disease. So it's not just one parent, two parents have to have it, and then it's a chance. Today we're checking for this, prenatal in the very beginning of pregnancy. Is mom have the trait? Does dad have the trait? Making sure to know what to expect when the baby's born. Now, what is sickle cell and what do we need to understand about it to take care of them? Well, we know it's those cells that are shaped like a sickle or like a C. And what happens as blood flows down through the vessels and the bifurcations, at times where you're dehydrated or your fluid is less, you've been in the sun, you have a fever, you haven't rehydrated, vessels get small, this cell gets stuck on a bifurcation and it can't go down. What happens with other cells, it backs up on top of it and it becomes swollen, red, and painful. And that is a sickle cell crisis. It's due to the vessels are small and blood can't flow. So, what do you think priority is to treat these? Now, most of you will say the pain is the one. Well, you're treating the symptom, not a cause. The cause is small little vessels. So you're going to bolus fluids, dilate those vessels. You're also going to put heat on it which dilates them. And what will that do is it relieves that one little cell that's blocking up that bifurcation. It allows those cells to flow and stops that crisis. Now, does not mean that I start a bolus. My other hand, I have pain medicine because it really hurts. But priority is absolutely for you to have the bolus going on for that child. So, with all that being said, what happens with sickle cell? The cells die quickly, they get entangled. When you can't get blood flowing below that obstruction, it causes local hypoxia, so lack of oxygen, which causes cell death, which could be you could make a finger turn black, a toe, any of these things can happen if it's not treated. So, what happens? Precipitating factors. Anything that affects the body's need for oxygen. So, I'm out running around, physical exercise, enjoying myself. I don't rehydrate. My body needs oxygen because I'm out there, being active. So, that is an increase in the need for oxygen, and I haven't replaced fluids, so those vessels get small. Trauma, swelling, pushes against those vessels, stops blood from going. We know infection and fever burns up fluids, and one of the things we always say is with a fever, increase fluid intake, right? Keep those vessels open. We know just fevers cause that. It's the increased blood viscosity, it's dehydration, blood's not flowing down and causes hypoxemia in it. And as I said, they're doing a lot of universal screening, not just the newborns. We are screening even before that. We're doing it, when mom becomes pregnant. So again, how do we treat it? Child comes in, the right knee is swollen, it's hot, it's painful. What do we do? Well, number one, you rest the leg. It's almost like a rice, okay, but not completely because we're going to give heat. But it is the squeezing of the vessels because they're very small, lack of fluid. So, number one, priority, bolus of fluid, dilate those vessels. Put heat on it, which dilates it. And then, if they need electrolytes, give it to them. And most children coming in a sickle cell crisis, I've never seen a hemoglobin above 7. They're usually 5 and 6, yes. It is not uncommon for a child to come in with a sickle cell crisis to get blood in the ER even before they go upstairs. That's how severely low their blood levels are. And most of the time, these children come in with low grade fevers, so antibiotics. On another note, just to bring it all in, any child immunosuppressed, whether rheumatoid arthritis, sickle cell anemia, even cardiac children, immunosuppressed, if you have a child with a fever of 100.5, they are all told to call the doctor because they have no immune system. They can go into septic shock right away. So doesn't matter, sickle cell or any other disease, they really need to be checked quickly and they need those antibiotics as soon as we can. Now, sickle cell children from a very young age, up till about 5 years old, when they've gone around and gotten a lot of diseases, so their body is a little bit more able to take care of itself. We give prophylactic antibiotics, and it's usually 10 VK, penicillin, and it's once a day. And that's just a prophylactic because these children are really exposed to a lot of diseases, and we're trying to help them. We will be monitoring how their blood is being produced, their reticulocyte count, and that's monitoring their bone marrow. And then, of course, if they are in a crisis, like I said, in the ER, hemoglobin are low, we're going to be given a blood transfusion because I'm giving now oxygen back to that child because they don't have enough oxygen by themselves. So prognosis of sickle cell, there is no cure. I've seen bone marrow transplantation done. Some work, some don't. Remember, there's always that risk of that rejection. Our prognosis is to try to prevent, those sort of episodes. It's trying to keep them hydrated. It's teaching these children how to take care of themselves. It's if they're in cold weather to keep warm, right? If they're out exercising, running around, keeping hydrated, all of these things, simple as that, can help them. So one of the biggest reasons that can cause sickle cell children to die is a bacterial infection. Because remember, they're immunosuppressed. There's no backup. There's nothing there to help them. So they have a fever. They need to call the doctor right away, get their antibiotics. So early intervention, penicillin as ordered, and then you have blood vessels in your head and in your lungs, right? So in the brain, it could cause a stroke, which would be a headache or blurred vision or, unsteady gait, could be those things. And then, of course, respiratory sort of mimics like a pulmonary embolus. So these are serious things. Those are your two biggest serious issues when we talk about sickle cell. And if we're suspecting that, tell a doctor right away, because then we need to do scans, making sure they're all right. And of course, with any child, any disease, try to treat them as normal children. Try to, if they want to play soccer, sure, let them play it, but make sure that they know that it's all about fluids and keeping themselves hydrated. It's a big thing, and frequent rest periods as they need. So that can help prevent that sickling. Now, thalassemia, very similar to sickle cell, as in it's a red blood cell shaped irregular. And these are rectangular shapes, is what I call them. And they have a very, very short life. And this is the people descendants from the Mediterranean Sea. Now, there's 4 different types, but you don't need to know all of them. You just need to know because you're mostly tested on the most severe, which is thalassemia major, Cooley's anemia. So those blood vessels are bursting. Well, what's inside a red blood cell? Oxygen. Patient's not getting oxygen. And 2, iron. These children become iron toxic with the amount of blood cells that burst. So that's the other problem with this. And we have to treat that with either iron chelation drugs like Desferal, or we need to pull off the iron in something called an apheresis. It's similar to dialysis, but it only pulls off iron. It's very specific to what you want to pull. And actually, nurses are the ones who run that at the bedside. They're taught how to do it, and it's just hooked up to a machine. So, thalassemia, usually we don't know at birth. And at birth, their cells look okay. But all of a sudden, about 6 weeks old, those cells change to those rectangular shapes and they start to burst. So, what do you see at that time? Well, why do we do all of this growth and development? And why do they need to know when they lift their head up and grasp rattles and all this? Well, it shows that they're delayed. It's that growth failure, too. Looking at their weight and their height every single visit, telling you, are they progressing forward or not at all? Not at all, or moving backwards. Something's going on. Let's go looking. So You do your CBC, you see it's thalassemia, and now your body's not going to produce blood in order to take care of it. And this child is going to be on blood transfusions. That is actually the treatment. And then it's also watching the iron in the blood and giving them medicines. So, care, um, this is a child who's always getting blood transfusions or chelation therapy, drawing bloods. It is a lot of work. Our job as nurses is to promote that compliance and help that child not be so stressed out with what's going on, and helping the family to adjust to what has to be done for this child weekly. It's not, every couple of months. No, this is a weekly problem. And then remember, they're getting blood transfusions. There's going to be reactions. Remember, they also could become those weird antigens and stuff in their blood, hard to cross match. So that's a big deal for thalassemia. So most of these children, if they're compliant, can live into adulthood. But again, the oxygen level goes down. The heart starts to beat, trying to keep up with the oxygen. It gets tired and go into heart failure. Many times they'll remove the spleen in order to stop those cells to be produced. And then it goes into multi organ failure. And they think, well, maybe a transplant will help. Who really knows? It's not really been said completely yet. Now, there's two types of aplastic anemia. The one we talk about is pancocytopenia. And as I said, this is you're anemic, hemoglobin, hematocrit are down, your white blood cells are very low, leukopenia, and thrombocytopenia is decreased platelet counts. So you're worried about everything. We treat this with very similar to leukemia treatment, immunosuppressive therapy, and maybe a bone marrow. Now let's look at bleeding. When you think of a child who's bleeding a lot, and what could it be? And you think of hemophilia. Now, hemophilia is bleeding. Now, your body has certain things that you need to work well to stop when the bleeding when you cut yourself. There's a factor 8, there's a factor 9, there is von Willebrand's, there's platelet counts, and many other things. Okay, that's all I'm going to work with you right now with. If you don't have them, what happens is you're just going to bleed and it's not going to stop. It comes from mommy. It's an X-linked recessive trait. Okay, our goal is with hemophilia, what is that factor that's causing it, so that when we are bleeding, we fell down, we get cut, we have bleeding going on, we fell on our knee and it's all ecchymotic and swelling and we need to stop it. I mean, we could do home therapy on these children, and I've seen parents do great jobs with it. So hemophilia A is factor 8, the biggest one. That's the one that's most common. Then you have hemophilia B, which is Christmas disease, and that's factor 9. And then von Willebrand was a scientist who found that factor, and it's a combination of that with factor 8. Now, when do you diagnose hemophilia? When would you know? Well, you're starting to see these bleeding episodes going on. If they are fell down, let's say, and they bump their knee and it's swelling and it's getting bigger and bigger, it's a clue. It's a hemarthrosis and ecchymosis, any bruising that's all over the place. Now, initially, it'd be nice if they did factors and we got lab results right away. And they don't come back. They're usually sent out somewhere. So what is a lab result that we would get quick? Well, we can look at PTTs, we can look at a PT, we can look at platelets, and there's other things we can look at. And later on, we'll figure out what factor, but you see a prolonged PTT, we know that that child, um, possibility of hemophilia. So how do we treat it? Well, you're bleeding because you have a factor missing, and you need everything in order to stop that. You know, you can give these home transfusions. I've actually seen a father do a factor 8 infusion in the emergency room, and his son came in, and it was one of those knees that was swollen and getting bigger, and he couldn't get a hold of his doctor, so he came into the ER, and our doctor said, give it, and the father wanted to, and I said, absolutely, why not? You do it at home. Probably some of the best things I've ever seen. He had washed his hands. The son picked out the thing he wanted, delivered it, and it was really good. Now, sometimes we're lucky and it's just a nasal spray, but that's not all the time. So with hemophilia, you're diagnosed, especially if you're like that young toddler, right? We want to make sure that we keep that environment safe, as in anywhere there is sharp edges, make sure they're covered, make sure that we protect it that way. So it's price. It is protects from injury. Rest when you're bleeding. Ice constricts vessels, so we stop bleeding. Compress it, ace bandage, hold it, or again, elevate it. Now, the prognosis, children can live pretty normal, but of course, they're not going to be playing football and getting hit, and bruising, because, that can happen. And our goal is to prevent things like the joints filling up with blood, because it will damage joints, and those children could end up in a wheelchair, and we don't want that. So, teaching parents, making sure giving factors as soon as you can. And then there is gene therapies, and they're working on it. Now, immune thrombocytopenia purpura. Remember, ITP is platelets, low platelets. Okay. Usually, it is following some sort of upper respiratory, some viral infection that's occurred, and the platelet counts are low. I'm talking below 20,000, and the low normal is about 100,000. So it is quite low. So you're going to see bleeding. I've seen children come in, the mother says, this kid doesn't go out, doesn't play. And I looked, and his legs are bruised and a petechial rash. I don't know. Well, after we found out, yeah, he's been sick, we do a CBC, and we find low platelets. How do we treat it? Well, these children are treated with IVIG, an anti-D antibody. And if you're the nurse taking care of that child, remember they bleed easily. So you're not going to stick a needle anywhere. If they have an IV, you're going to be giving all the meds there if you need to. And hopefully you can pull your morning lab from there, because you don't want to stick anything, because they will bleed. You're going to monitor them from bleeding, their nose, their gums, their urine, their stool. You're going to be looking for ecchymotic areas, petechiae. And you're going to be looking, because they will be, with the administration of the IVIG and anti-D, we'll be looking at platelet counts every morning. So you're going to be looking at that. And they say sometimes corticosteroids, most of the time. they're going to be giving steroids for this. Now, one of the ways actually we diagnose ITP is nosebleeds, epistaxis. And what happens is there not one, I said there are multiple nosebleeds. It could be leukemia, thrombocytopenia, or it could be some sort of bleeding, lack of factor something. A lot of times I find it was ITP in my career. Now, you have a child, it has a nosebleed. Remember the ages. I mean, preschoolers think when blood's coming out, it's coming out and they're gonna die, and they go crazy, and their heart rate goes up, and they're screaming and yelling. And what happens? Heart rate's up, blood pressure's up, they're bleeding more. So, number one, try to calm the child down. Take your thumb and forefinger, put it on the nose, apply pressure. And what we do is we put them forward. Blood can come out of their mouth. We don't want them swallowing it because then they'll just vomit. And if after 10 minutes they're still bleeding, they need to get to medical care, whether to their doctor, urgent care, ER, they need care to stop that bleeding. Now, immune, HIV, AIDS. We look at two different things in this course. We talk about mom pregnant with her child who's HIV positive. And then, of course, it's that adolescent risky behavior that have the risk to get HIV. So, a mother who is HIV positive at 22 weeks can go into heart therapy. It's the highly active antiretroviral therapy. And that's trying to help boost the immune system on this child. So at birth, these children are born, and we are going to start antivirals on the child. Now, you think a mother gives, HIV positive, delivers an infant, you're going to say they all have HIV. No, they can auto convert up to 1 year later. I've actually seen triplets born. One had AIDS, one had HIV, and one had nothing. So that shows you the variety of what can happen. Our goal with HIV, AIDS, and giving these antivirals is to improve their immune system. Excuse me, my voice is terrible tonight. Pneumocystic pneumonia, PCP pneumonia, most common of all the opportunist infection in children. And that's about 3 to 6 months that we see it. And again, this is a virus, so we'll be treating it with antivirals. Now, treating hematologic, immunologic disorders, well, it's number one, getting those lab values, understanding where you are. CBC tells a lot. If they need blood, packed red blood cells, whole blood, platelets, whatever they need. Remember to always watch for reactions. And as a nurse giving blood, always follow whatever the hospital protocol and policy is. Where I worked was check it, double check with another nurse, hang it up, take vital signs before you start. 15 minutes later, come do another set of vital signs, and then every hour do another set. It's like 15 minutes later, I've seen children go from no fever to 102, and that was my reaction. So stop the blood, send it back to the lab, to the blood bank, okay? Another thing we do is we look at the apheresis. Remember, that's how where we would pull things off, whether it's iron or it's getting platelets from a healthy donor to give it to that child. Many parents want to do that. Another thing we look at is bone marrow aspiration. Now, I don't know if you've ever had the opportunity to watch a bone marrow aspiration, whether it's in the iliac crest or in the sternum. They take that blue thing, and that needle is quite large. And yes, they're sedated. Yes, they do all this infiltration on the skin and then deeper. But they take this thing and it goes going into the bone. It's quite scary, especially for a child. Now, yes, we do all that numbing stuff, but it does hurt a little bit. Even with that, again, with children, if something is gonna hurt, be honest, okay? Let them know. So if both parents have sickle cell, what's the chance that each of their children will have it? What did I say? Mommy and daddy have a trait. How many other children, what's the percentage that each child could have the disease?
25%.
Okay. It is 25%. That's why today that we are checking those things. Thank you. All right, cancer. So, neoplastic disorders. Most of, well, almost half of all childhood cancers are blood forming organs. So, it could be lymph nodes, spleen, or it could be in the blood, right? Leukemia, lymphomas. Now, leukemia, more in boys greater than one. Onset, peak onset, 2 to 5 years old. They're young kids. And Down syndrome children are at a higher risk for leukemia than normal. So poor Down's children, they're more apt to get congenital heart defects, they're more apt to get leukemia. Also, they're apt to get hypothyroidism. So these are three biggies in those Down's children. So remember that. Now, what is leukemia? Well, it's about the white blood cells. What do white blood cells do? They fight infection, right? If your white blood cells don't work, what happens? You're apt to be going to septic shock because there's nothing there to prevent infections, right? So the word is unrestricted proliferation of immature white blood cells in the blood forming tissues. That means white blood cells are formed, but they don't work the way that they should. So it is a big concern, infections. So, what would you see? Now, my neighbor, she was older, okay? She was that preteen, 12, 13 about area. Went to the ER complaining of being tired, aching everywhere. Her knee was a lot of pain. She had a low-grade fever and she had ecchymotic areas on her that she didn't know where they came from. This is the absolute things and symptoms you see with leukemia. They did a CBC and a blood smear, and she had ALL. So there's ALL and there's AML, acute lymphocytic leukemia, and acute myelolytic leukemia. ALL is easier to cure than AML, just to let you know that. So once we determine, yes, she did have leukemia, and they looked at the cells, and yes, they were there. They did a lumbar puncture. And why? They want to look to see, is it already in the central nervous system? And then, of course, they did a bone marrow looking at the cells being produced. Same thing. Tell them it's going to hurt. Now, once you get the diagnosis of leukemia, what we're going to do is start chemotherapy. Now, they're going to put in a central port. Now, some central lines hang out of the body. your Broviacs, right? Your Centraline, subclavian IVs. Well, with leukemia, the port is underneath the skin. So once we don't need to give any fluids or whatever, we can take it out and there's nothing there so that they can take showers and go swimming or do whatever they want to do because they don't have that IV sitting there. Now, the first 4 to 6 weeks, they give, it depends on the cancer and the physician and what sort of did they go to some seminar and learned about a new type of treatment. It could be 2, 3, 4 types of chemo, okay? And they give it 4 to 6 weeks. And the goal with it is remission. Did you hear me? Induction, 4 to 6 weeks. The goal is remission, but we don't stop there. We go into the central nervous system and we put chemotherapy intrathecal there. Then we give some more consolidation. And why do we do it? Well, there's probably some hidden cells somewhere, and we don't want them to go and reproduce. And again, we have to start back from the beginning. And then we go into maintenance. So the most important thing here to remember is induction therapy. The goal is remission. They're going to be wiped out. You're not going to be able to see them anymore, but you can't be tricked. They're there somewhere. Now, another treatment is your hematopoietic stem cell transplantation. Now, did you ever, um, when you had children, the babies, they want you to take the cord blood, right? And they want that cord blood to be, hold on a second. My husband got it. My 91-year-old mother-in-law. I apologize. So at birth, they say, do you want to save the cord blood? But it's expensive, right? And you're like, do I or don't I? Well, if in the future your child had leukemia, this is actually the best in order to treat it. So autologous, automatically mine is the best. That's how I remember autologous. That's from me. That's the best because it has all my stuff in it. Then allogenic is all the others. So autologous, automatically mine, the best. Allogenic is all the others. And of all the others, your brothers and sisters with the same mother and father are the best choices if we need to do a transplant, and they will give it to you. Now, you don't need A positive and A positive like blood. It has nothing to do with this. Okay. Of course, with any transplant, you always worry about graft versus host. And of course, that can cause organ damage. But when there's no choice, you have leukemia, it's not being cured, you can try, if you don't have autologous, my own stuff, to try the allogenic. The others is better than not trying it all. So, management. Well, of course, you're always going to prepare that child, making sure they know what's going on. You're honest when it's going to hurt. They do have pain. Make sure you're medicating them. I mean, low dose around the clock is the best of all treatment. And then remember, there's no white blood cells when we start leukemia and the treatment. And then, of course, with chemo, you're wiping out what you have there and red blood cells and platelets. You are at risk for so many things during this. Now, that myelosuppression, you worry about infection. Remember, as nurses, washing hands, putting a mask on are your biggest thing you can do to help. Again, platelets low, worry about hemorrhage, looking for bleeding precautions, looking for petechiae and ecchymotic areas. And of course, anemia, what does that mean? They tire out easy again. So making sure we don't overtire these children. and as nurses, being careful with chemotherapeutic agents. Now, I'm going to tell you something about children and working with them with cancer. One of the highest paid bonuses, sign on bonuses, is children with chemo and cancer. And not just in Miami, where I live, but all over the country. It is a highly desired area. Now, it's hard to work it. Yes, many of them die, but I worked in the cardiac ICU for many years, and they didn't all make it through. It's not that they lived or died. It's, as a nurse, what did you do for that family, for that child? I still are in contact with many parents that their children died, but the bond was made because of how I cared for these children. And it can be extremely rewarding that way. So if you're interested, great profession. So prognosis of leukemia, it depends. What was the white cell when they came in? I mean, my next door neighbor was 0.1. That bad. It could have been 0.01. Again, there's no white cells. It should be 7 to 10. That's about the normal sort of lab results. How old was the child? And was it ALL or AML? Remember, ALL is better than the other. Males and females make a difference. And what is your blood type? Are you that blood type that's very rare? Because when you need blood, you need blood. You can't wait. So that makes a difference. Chemo is done, radiation, it's done. Chemo is a combination. It's one, the other, or both. Treatment of cancer is all of those symptoms that I told you about my neighbor: pain, fever, ecchymosis, petechiae, bleeding, tired, general malaise, anemia, and, it could be vision also that is there. And that can alert you. And what do we do? Well, a simple CBC can tell you. Now, here's a concept that, we can use it for leukemia, but we can use it for any child who is immunosuppressed and has a neutrophil count lower than 500. Now, I think the normal level is above 2000, or at least up there somewhere. 500 and lower means my body has no defense against infection. Well, what is that going to mean to you as a nurse? You receive report, you have 4 or 6 patients, whatever it is, and you find out as you're looking, the neutrophil count on one of your children is 500, and the nursing assistant just told you they have a fever. Oh my goodness. Priority, priority. That child needs you to go in, do an assessment, call a physician. We need to start antibiotics now. And if they're in a semi private room, they need to be alone immediately. Prevent that infection, because they will go into septic shock and they will go quick. Other things that can happen: chemo, hemorrhage, of course, platelets go low, right? That anemia, like I said, especially during that induction stage. So, again, be careful. All of the exercise, giving them time to rest. We know nausea and vomiting and chemo go hand in hand, right? When I started nursing, and I still remember this clearly, I couldn't give anti nausea medicine until after a patient vomited. Doesn't make sense today, does it? Because today we know that we're going to give it before these children vomit, because we know it's going to happen. I mean, we're using cannabinoids, which is a great thing. It has a lot of good stuff. The only thing with cannabinoids, and parents, they need to be honest with a physician any alternative type of care they're given. So the physician knows what you're doing so that they can work together, as long as it doesn't interfere with the care. um Whatever works, it works. Another thing is altered nutrition during this whole thing. So again, monitoring intake and output and nutrition. What are they eating? And we monitor that by height and of course your weight. And of course there are blood tests. I mean, looking for protein, et cetera, et cetera. So with these children, they're anemic, they're tired, right? They have no energy. They need good nutrition. So high protein, high calorie, full fat. They can eat less and get the same nutrition. Nutrition, 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 right? They get mucosal, mouth to anus can be all irritated, making sure that if it's in the mouth, that we do a mouthwash in order to help them. If it's in the rectum, let them sit on sitz baths, give them what they need or medicines, whatever. And the other thing is remember they're in pain. Children with cancer have pain. We give pain medicine. Pain medicine causes constipation. If they bear down too hard, they can cause a stroke. So again, stool softeners and then getting them up and moving and preventing all sorts of, things with them. This says severe jaw pain, give pain medicine, they'll eat a little bit better again. They can have blood in their urine. And of course, you talk about cancer and chemo, you're talking they lose their hair. One of the things that I did with girls is I would have ribbons. I'd go, believe it or not, Walmart, these little round balls of like quarter-inch ribbons, all colors. And I would bring them into the child, certain colors. What colors do you want today? And her and I would have a little headband on with these ribbons. So now we are not being upset with hair loss. We're saying, I've got a pretty ribbon in my hair. And that distraction worked very well. We know steroids are given, and of course, the altered body image is a big thing, especially in older children, making sure that their jammies aren't too tight because that will make them uncomfortable. Always preparing for procedures, like I said, getting them sedated, being on their level, and of course, topical and then deep infiltration of lidocaine will help. Pain management, as I said, making sure they get it. As I said, that little pain medicine, you know, doses around the clock are the what we want to do. And make sure that pain medicine guy's there. It's usually anesthesia. Make sure we get them there to get the proper pain medicine. These children with cancer, we're thinking about just the cancer we're forgetting about. They have teeth and, they need to get their vaccines, etc. But we do need to be careful with that. With getting x-rays for their teeth, it's radiation, and immunizations. Live viruses are contraindicated. And the big one is chickenpox. And chickenpox is serious in children. So they do have an immunoglobulin that they get instead. Then it's the question, can the family get their immunizations? And most of them, yes, but it's always asked the question. All right, lymphomas. There's a question on the exam. It's about lymphomas. There's two types, Hodgkin's and non-Hodgkin's. And how are you going to remember the difference? Well, Hodgkin's is a lodge, it's a house, it's big, I can see it, I can touch it, I can feel it. It's there, it's a house, it's a lodge, it's a Hodge. Non-Hodgkin's is diffuse, it's all over, and it's very hard to feel. So Hodgkin's in the lymph nodes, and it's from the clavicles up. So what are you going to see? The neck. And there's great pictures here, big swollen lymph nodes, and they start to push against the airway, and you start to see that cough. and they can't swallow and they get uncomfortable and don't eat and of course lose weight. So they don't hurt. They look worse than what they are. You touch them, no, don't hurt. How we diagnose that this is that Hodgkin's lymphoma. This is the house. I can feel it and touch it. Well, are they fever, anorexia, weight loss, cough, et cetera? History physical. BBC, let's look at white cells, let's look at red blood cells. And then the biggest thing is the lymph node biopsy. They just take and numb it, go in, take some cells, look at it, and it's Sternberg Reed cells that'll be present. So that's Hodgkin's, the lodge. That's you can see it and feel it. We need to shrink it, we need to give chemo, and usually that's what works with these children. But with the chemo and radiation, there is a concern for infertility with these children. Now, non-Hodgkin's, it's not a house, it's not a lodge. I can't see it. It's diffuse, it's everywhere. It's not just from the neck up. No, it's everywhere, okay? And this is something that you need to find an area and again get a sample, a biopsy of it to confirm the disease. Same radiation, same chemo, and sometimes intrathecal in the spinal column, in case they feel it needs. So Hodgkin's, big, above the shoulders, doesn't hurt. I can touch it, feel it, see it. Non-Hodgkin's, it's not a house. I can't see it. It's diffuse. It's in all of the lymph nodes somewhere else. Now, brain tumors. There is a tumor in the brain and it gets bigger and occupies space. It's either cancerous or not. Now, what would you see with a child with a brain tumor? A headache that can wake them up at night when they're sleeping, vomiting not related to eating at all. Your symptoms are going to get worse as time goes on. And you might even see like gait, ataxia sort of things. You know, depending on location, you might see diabetes insipidus, that's pituitary area, and failure, another pituitary area. These are things you would see. How would we diagnose? Well, first of all, it's just a simple x-ray. After we get all of those signs and symptoms, then we go to CAT scan, MRI, and a biopsy, determine what we need to do. When we do chemo, radiation, and we do surgery, now that radiation chemo shrinks that tumor because we want to take out as little as possible of that brain as possible, right? Now, post-operatively, we've removed something. There's a space left in there. Do we turn them on the side or not? How elevated does the head go? One of the big things is fluids, making sure they don't get too much fluids because that extra fluid can swell the brain and cause more problems of it, right? And again, trying to keep the kid comfortable and the family too. Now, neuroblastoma, it's not that common. So basically, it starts in the abdomen, a tumor that gets bigger. So it starts on one side, takes up the abdomen. We usually don't see it until it's already in the brain. And you might see things like the eyes bulging or swelling around, or some neurological seizures, something that's happening. It's not that many children. It's only about 6%. I've only seen one of these in my career, and remember the outcomes are not great because it's tumors in the brain, it's tumors in the belly. It's a lot to have to remove. Bone tumors, osteosarcomas. Usually with bone tumors, what you start to see is this achy, dull pain. If it's in the lower extremities, it's going to be limping. It's like pain, which becomes more and more and more. You might feel something, you may not. The thing with bone tumors, most can be cured. So, how do we diagnose? Well, number one, of course, is the history. What's happening? My kid, starting to limp, it's getting worse. It's that right knee, it looks a little swollen, something's going on. So, we rule out infection, CBC, right? And then we do that x-ray, we look at it, and we go further, CT, MRI, and do a biopsy. Osteosarcoma is many of the times the femur bone. Now, many tumors, we just remove the tumor, right? We can't with osteosarcoma. The whole femur bone has to be removed. So the whole thigh has to go away. So what are we going to walk on afterwards? Well, they take the lower leg, connect it back where the upper leg was, and they turn it around. You see that picture to the left? That foot's facing backwards. And why? That's where we can put a prosthesis. So our goal is to salvage the limb. If we need to, it'll be amputated. Wilms tumor, a kidney tumor, boys ages 3 to 5. And again, I've seen one of these. It was a little boy after the Haitian earthquake. I was in triage, and a religious group picked this child up at the airport with his records and brought him to me. And I said, "So what's going on?" And they go, "We were just told to pick him up and bring him here." So I looked at the records. They're all in French. I don't speak French that well. So I had to do an assessment. So I had to build rapport with a child who doesn't speak English, and I did pretty good with it. And I did vital signs, listened to the lungs, checked his neurostatus, and then I checked his abdomen. On the left lower quadrant, I felt was like a softball sized mass. And I have no clue to this day why I knew it was a Wilms tumor. The thing about Wilms tumors is they're very fragile, and you do not want to touch and manipulate them because little micro emboli or metastasis will go all through the peritoneal cavity. So the thing with these is we do surgery, maybe radiation, and we take it out. Now, it's a big surgery. They have to open up the abdomen, and they have to go through the intestines to the back. So it's a lot of manipulation. So post-operatively, you worry about their intestines working, worrying about paralytic ileus because that manipulation, and it's a kidney that we're working with. So urine output, big thing that we do. So what do we do for these children? Big sign on the chart, over their bed, even on their forehead, really. Do not palpate that tumor. Leave it alone. That little manipulation can cause little micro metastasis to go around. So you do not want to do that. A retinoblastoma is a retina tumor, and it looks like, ever go outside at night, the lights are on, and you look in the distance, there's a cat or a dog, and you see these shiny white things? Well, that is cat's eye or a white glow, and it is cancerous. The whole eye will need to be removed, but they do a radiation, they do chemo, and then they take it out. As a nurse, we need to ask, has there been any signs, symptoms, anything with the eye that you've seen before this? And there may be no history, or there may be, that child has always had, some sort of issue there. But as a nurse, that'd be some questions. Now, germ cell tumors. This is testicular tumors. Women check their breasts every month. Men should check their testicles. Now, I had an 18-year-old boy come into the ER. I'm working triage, which I work quite a bit, and complaining of testicular pain. The nurse who was in the room with me did the physical examination and found out his testicle was like the size of a melon and hard. So we sent him for ultrasound, and we also did a uh, X-ray of his abdomen and his lungs, like a big X-ray. He was already metastasized to his lungs. It was cancer. This 18-year-old boy died 3 months later from a testicular cancer. Okay. So again, germ cell tumors. Liver tumors, remember there's a bunch of lobes on livers. We can remove just one. They actually do pretty good. You know, today, cancer is more children and adults are surviving. The 80%, I'm sure it's even better than that. Know that with cancer, it's making sure that we keep that child, understanding what's going on and being a part of the whole process. Even young kids, they understand what's going on. I mean, these pictures in Facebook, I love to see. Cancer free. I've met quite a few of them in my career. Any questions so far? A lot of stuff, huh? Who wants to win a cahoots today? Genia, I see you there. Annie, so you ready to win? Jesus looks like he's ready to. Yep, there he goes. Just do your best. Make sure those who have not given me your diagnosis yet, think about it. What would you like to do it on? Do you want to do it on a PFO? Go for it. It'd be a great one. All right, let's get going. I know you're all tired. Week 6, halfway through after this. What is priority treatment for a newborn of an HIV positive mother? What are we concerned about? Our biggest concern is about their immune system. Remember, HIV is all about they don't have protection. So, again, improve their immune system, antivirals, antiretrovirals, whatever they need. What are symptoms of sickle cell anemia? Remember, it's those blood vessels get small and they usually get stuck in bifurcations, and then the cells back up and it swells, and below, they're not getting blood, they're not getting nutrition, and it's hand, foot, pain, vision, whatever, whatever. It is all due to blood can't go through vessels. What kind of hematocrit would somebody with sickle cell have and why? In the beginning, I talked to you about increased blood cell destruction, decreased production. Which one is it? It is lower because sickle cell red blood cell production is decreased. As I said, most children coming in with a sickle cell crisis, most of them are getting a blood transfusion in the ER even before they go upstairs. That's how low their hemoglobin is. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? So the crisis is blood's not flowing through the vessel. It hit a bifurcation, it stopped, and the other cells are going behind it. What are you going to give priority? You're going to start an IV fluid and you're going to put hot packs on it to increase it. Now, why not morphine? Well, you're treating the symptom, not the cause. The cause is your vessels are small. Your goal is to increase those blood vessels through fluid, and then the hot packs also dilate. Okay? Very common mistake. What is the reason children with iron deficient anemia are easily tired? When you have no hemoglobin, you have no oxygen and you are tired. A multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? Iron supplementation, oral. What are you going to do? Remember, iron stains the teeth. So, on an empty stomach, so the stomach acid works. Orange juice, more acid, and you through a straw because the teeth will get stained. And remember, that iron turns their stool tarry, black looking, and it can really scare parents. Stomach should be empty and never, ever, ever with milk. Aplastic anemia includes a depression of which blood cells? As I said, it's a little bit of everything. So it's your hemoglobin, your hematocrit, and your platelets, um, and your white blood cells. Everything is touched with that. Most common type of anemia is iron deficient. Good job. What causes pernicious anemia? Again, it's another nutritional problem, and it's called a B12 deficiency, the intrinsic factor. They can't break down the food for the body to use. And B12 deficiency is usually they give, injections of B12. What symptom is the single most common symptom of anemia? And that's fatigue because there's no oxygen, there's no nutrition. Very good. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, this is that rectangular shaped cell, right? And it bursts. And when the cells burst, it loses oxygen and iron. And it's so much iron, many times they need to be placed on some sort of iron chelation therapy, whether medication or an apheresis machine to pull off the iron. What lab values will you see with hemophilia? Hemophilia is a bleeder, right? Yeah, we have all the factors, factor 8, 9, von Willebrand. Well, what would you see with just, quote, normal lab values? And that's the PTT. It is prolonged, but everything else is okay. And then, of course, you need to wait till the lab comes back because it's sent out, and then you figure out what factor it is. What is immune thrombocytopenia purpura? ITP. What did I say about ITP? What is a P? And it's all about platelets, usually due to an upper respiratory, some viral infection, and usually it's an acute stage. We can turn it around. But they say if it goes on over a year, it's a chronic condition. Thrombocytopenia can cause the following symptoms. The thrombocytopenia is decreased platelets. Platelets help with bleeding. What would you see? Petechial hemorrhage, ecchymosis, and epistaxis is usually how we diagnose it many times. Oh, multi. Child with hemophilia is falling and the knee is swollen, painful. Treatment would include what? Remember, the whole thing with hemophilia and swelling into joints is to protect them. You know that hemoarthrosis causes irritation and it can destroy those joint sacs. And we don't want them to be in wheelchairs. So the treatment, it's that rice. It's rest, ice, contain, elevate. Get it up, get it, wrapped, and then give the factor if you know what the factor is at home. What is the priority nursing action for suspected blood transfusion reaction? Turn it off immediately. And it could be a fever, could be many things, but I think the most common one I've seen is a fever. A child is admitted with neutropenia. What nursing action takes priority? Neutropenia, not enough neutrophils. What is this issue here? Not enough white cells. What do they do? It's all about infection, right? So, what is our priority when you don't have enough white blood cells? It's all about just washing your hands, right? Good care, just basic sort of care. Washing hands, putting a mask on if you have a cough, right? Protect. Which symptoms would a healthcare professional expect to see in a child with leukemia? And this is just like what my neighbor went into the ER with. So remember, their hemoglobin hematocrit's low, their platelets low, their white cells low. So bruising, that's your PT. Fatigue, that's your hemoglobin hematocrit. And then they have the bone pain. Your child with ALL has had recent lab results. The platelet count is 10,000. Your nursing action. Well, I say It doesn't mean that you just have to have ALL. Any child with lab results, platelet count of 10,000, what are you going to do? What does low platelet count mean for this child? This child is at risk to bleed, okay? Whether ALL or a kid that's, quote, no diseases, but all of a sudden the platelet counts are 10,000. Leading precautions. A multi. A child is placed on bleeding precautions for ITP. What interventions would the nurse do? This is an important concept for you to know. Bleeding precautions. ITP, low platelet count. You're gonna, no injections. You don't want to create an area to bleed. You're going to be watching those CBCs, and usually with the IVIG and anti-D therapy, we want to see a daily CBC, seeing what the body's doing. Is it, correcting itself? Always going to be checking active bleeding in the gums, in the urine, in the stool, bruising anywhere. And it says corticosteroid symptomatic. Most ITP children will be getting corticosteroids. Child with Wilms tumor. What action by the nursing student causes the faculty member to intervene? As in, what is this nursing student doing wrong? Right? So the thing about Wilms tumor is very fragile. And if you touch it, manipulate it too much, it's going to cause little micro pieces to fall off and create, metastasis. We don't even do a biopsy before we do surgery on these children because that puts a hole in it and it allows the cancer to get out in the peritoneal cavity. A child with ALL has a fever of 100.5. What should they do? This child's in treatment and they're home and you take their temp and it's 100.5. What have they been taught they need to do? Remember, they have no white cells. They have no defense against any infection. They need to get medical attention immediately and they need antibiotics started. They have an infection going on. There is nothing in their body that can fight it. They need the antibiotics quick. A child's having a bone marrow aspiration. What should you tell the child? Remember, these do hurt. I mean, as much as we put the outer topical and we do deep tissue um lidocaine, it still is going to hurt. Be honest, but say, I'm going to do everything to help you. Most common clinical manifestation of a retinoblastoma. So it's a retina and it's a cancer of the retina in the eye. What do you see with it? It's actually the first thing that, oh, there it is. And then you do your investigation. And it's called a cat's eye reflex. It's a white eye. The retina gets the tumor, and you see this it's like white flash when you put light in front of their eye. Your child's been diagnosed with a retinoblastoma. What information is important? What do you need to ask these parents or child about this? Part of your assessment. So this is when you want to know anything that's gone on with that eye. Has it been tearing? Has it been an infection? You know, blurred vision. What is it? History is very important. A goal of surgery for a child with an osteosarcoma. Osteo is bone, sarcoma is cancer. We usually say that osteosarcoma, when we're giving your test, all about the femur bone having this fuzzy area and it's cancer. So remember, you can't just remove a tumor. You got to take a whole bone out. So our goal is to take that bottom leg, that calf, and put it up into the hip and create something that you can put a prosthesis on so these children can be mobile. Instead of nothing there, what are you going to do to put a prosthesis? It's going to be more difficult for those children to be mobile. A child's complaining about those skin markings for radiation therapy. They should be told what? I mean, many times they've been annoying and they give parties, that hey, we can now take off these marks and do a birthday cake type. Yeah, they're gone. Let's celebrate. But these marks, what they do is they're usually purple. And like for instance, the eye is one of the big ones they use it for. They have found where they need to direct the radiation gun and they want to do the same place all the time because it's more effective that way. If you take it off, they've got to remark the child, and who knows it's going to be the same. So it's very important that they don't wash it off because they want the same radiation in the same place every time. It's more effective that way. When distraction is used, it helps what? So distraction helps in so many ways. I'm forgetting if I'm in pain. I really wanted to do that video game. And then they're not worrying and thinking about all those things. And it's really a great thing. Put on a video, give them, let them play Roblox or whatever their game of the week is, right? That will take them away from worrying and thinking about what's really bothering them. What assessment question needs asked to a child with possible rheumatic fever? Question from last week. So, rheumatic fever is due to a strep infection that wasn't treated or not completely treated. So, they would do something called an ASO titer, anti-streptolysin titer. Strep is in there, and that will say there was strep. How do you treat rheumatic fever? Well, we give an antibiotic, usually longer term. The biggest concern with rheumatic fever is mitral valve damage. So that can't be turned around, but everything else can. Signs and symptom of asthma. So they're coughing, they're short of breath. The biggest thing is remember with croup, with epiglottitis, it's all upper, it's inspiratory stridors, like trying to get it in. Asthma, it's the lower lungs get swollen and traps air and it can't push air out. And that's expiratory wheezing. Very good, guys. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Which one of these are an emergency, needs to be investigated like now? I mean, we have common things, and then we have those that are more severe. It's the headache and it's the chest pain. Normal is hands or feet or a knee or an elbow or a wrist, but the headache could be a stroke, chest pain could be cardiac, something going on. Absolute contraindication for nasotracheal suction include which of the following? Always are going to throw in something from last week here. Keep you thinking. So anything with the upper airway, epiglottitis is already swollen, croup is already swollen. Tonsillectomy, you don't want to cause bleeding because they can bleed. And I've seen tremendous amount of bleeding from just a physician looking at the throat a week postoperatively. And the child came to me throwing up clots of blood. So all of those, do not leave it alone. Iron dextran is given via which route? Remember, this is all about iron deficient anemia. Sometimes they give an oral, sometimes they need to give it IM, sometimes they just need a change in diet. It all depends on the child and how severe the deficiency is. But iron dextran, it's brown, it burns, it stings, it'll stain the skin. So it is IMZ track. Push the skin back, give the injection, pull it out, and I call it lock and load. Basically, it keeps it from draining back out. If a child was to receive their own bone marrow, this is called a what transfusion? And that's your automatically mine autologous. What cancer may present with painless, firm, and enlarged cervical nodes? So above the shoulders, cervical, these are swollen. What is that called? And that's your Hodge, that's your Lodge, that is, your Hodgkin's lymphoma. Very good. A multi. When teaching about sickle cell disease, you would include what? I mean, I think we've learned that sickle cell disease, yes, they've got these sickle shaped cells. Yes, they die quickly. But the big problem is them getting all clogged up and creating that pain, etc. So, again, keeping those vessels big, dress warmly when it's cold. If you're in pain, start that pain medicine quick. You're going to keep hydrated. And any fever, you're immunosuppressed, call the doctor. We need antibiotics. Thalassemia major is treated primarily with what? These are your rectangular shaped cells that die quickly. They disperse oxygen and iron, right? Into the body, into the blood. How do we treat it? And it's blood transfusions. There's no other treatment. It is blood transfusions. A multi. Treatment of an osteosarcoma include what? Osteobone sarcoma cancer. And as I said, mostly it is the femur. The big thing is we want to salvage the limb. That is our goal. But we're going to give chemo, maybe radiation, and sometimes we have to do an amputation. Stem cell, not for this one. A multi. Who are the best donors for a bone marrow transplantation? So when we talk about bone marrow, automatically mine is the best, right? If we have it, and then all the others. And of all the others, it's your siblings of the same mother, same father. That is your best choices. What is the most common opportunistic infection of children with HIV? And it is PCP pneumonia. That's number one, okay? It's respiratory usually. What would you consider to be neutropenia or a low neutrophil count in children? And we usually see this when we're doing that induction part of chemotherapy, but it doesn't mean that. Sometimes children, due to sepsis, whatever, have neutropenia. Now, neutropenia is a true and real emergency, especially if the child has a fever. So less than 500 would be the number. It's less than that, I need to see this person first. And if they have a fever, I need to call the doctor. I need an antibiotic quick. A primary characteristic of a brain tumor is, and it's all about the symptoms, whether it is nausea, vomiting, not related to eating, headache, waking them up at night, symptoms worse over time. It gets worse and worse. The optimum treatment for an osteosarcoma is what? What would be the best outcome of that bone cancer? Osteo, bone, sarcoma, cancer. Usually, when we talk about it, it's the femur bone. So, the optimum treatment is to salvage the limb because we want to get that bottom piece up and attach it so there's a place to put a prosthesis so they can become mobile, right? Because many of these children are that pre adolescent body image, right? They need to be able to be up and walking. And last question, a child's receiving the induction of chemotherapy. What does that mean? And induction, it's the first 4 to 6 weeks, and it's intense, intense. Goal is remission. Very good, guys. Let's see how we did today. Any's, good job. Number two, Dee Dee. Number one, Jania. Good job. And Steph and Mel. So that's the end of week 6. Remember, I still need to have your whatever diagnosis that you want to do for your pediatric assessment. Remember, this week is all about getting those reviews and looking at that. Anybody who needs to meet with me, please send me a message. I would love to meet with you. Just you or 3 of you, it doesn't matter. If you need help, I'm here to help you, okay? Any questions? Thank you, guys. Have a good night.
Thank you. Good night.
You're very welcome.